aspects of arthroplasty. And today we have a very interesting topic, that's total hip replacement in the post-acetabular fracture scenario, and how to reconstruct the pelvis and the acetabulum, how to manage acetabular defects, manage non-unions, and pelvic discontinuity. We've really got a galaxy of stars this evening, including our international faculty. I'd like to welcome Dr. Nikhil Shah from the UK, along with the rest of our members of the IAA. And we will do individual introductions as the speakers proceed. But without any further ado, I'll hand you over to Rajiv, because Dr. Sen, who is the moderator for this evening, is unfortunately caught in a flight and will be joining us later. So over to you, Rajiv, to take the thing forward.
Thank you, Ronan, and welcome you all to this 34th webinar of Indian Arthroplasty Association. And as you all know now, that for over a year, almost 2 years, Indian Arthroplasty Association has been holding a monthly webinar on very important topics. We call it 360 degrees because we try to cover one topic in all respects. And today we have a very interesting and important subject, which is total hip arthroplasty in post-acetabular fractures, reconstructions, acetabular defects, non-unions, and we have many very known speakers today. The first one will be Dr. Nikhil Shah from UK, and we all know him well and his good work. After him, there will be 6 panel discussions. So Nikhil, before I detail any and start you, and Dr. Nikhil will be speaking on impaction grafting in post-acetabulum fracture scenario.
Can you see the screen?
Yes, we can.
So am I okay to start?
Yes, please. Yes, please.
So good afternoon, everyone. My name is Nikhil Shah. I work at Wrightington Hospital, and I'm part of the regional pelvic and acetabular fracture service. And we also perform a lot of joint replacements here, as you know. The remit of my talk is to cover the role of impaction grafting in performing total hip replacements in different scenarios that we encounter following an acetabulum fracture. So the role of bone grafting is basically to replace the missing bone. And I'll illustrate this point using a variety of different scenarios, which include a late or an acute total hip replacement, some ununited fractures, and more recently, periprosthetic acetabulum fractures. We know that Letournel described 2 peaks for total hip replacement. One is the early peak, which occurs in the first 5 years after the fracture, and the late peak that happens after about 10 to 15 years. And Dr. Dana Mears did a lot of work on early total hip replacement. We know that this is a difficult operation. It has a higher risk of complications, and it needs the skills and the experience of not just an acetabular surgeon, but also an arthroplasty surgeon. Traditionally, poor results have been reported in the literature after total hip replacements done for acetabulum fractures from most centers. But from Wrightington, Charnley reported good to excellent results. What we do know from the literature is that if you can do bone grafting for the missing bone, then the results improve dramatically. So when you look at bone defects, the first question to ask is, what exactly is missing here? And what is missing is bone. So how do you replace bone? We don't believe in replacing bone with heavy metal. We like to replace bone with bone. And the purpose of this is many of these are younger patients. They will inevitably have future revision surgery. And the philosophy at Wrightington has always been to make your revision look like a primary, restore the bone, and prepare the bone for the next operation. A simple way to classify these defects is to look at whether these defects are segmental defects or cavitary defects. Cavitary means the acetabulum is basically expanded and the volume is increased, and segmental means one of the pieces of the acetabulum is missing. And this can be the posterior wall, the superior wall, the anterior wall, or it could be one of the columns. It could be the quadrilateral plate or the floor. And then based on that, you can plan bone grafting and you can plan your reconstruction. So this gentleman was in his mid-50s. He had polytrauma with sepsis. So by the time he reached me, it was already 6 months after the injury, which had been managed non-operatively. You can see that there is significant deformity of the acetabulum. There is a malunion, and there are various fracture gaps where the fracture has remained ununited. So how would we deal with this? We have to address the protrusio, we have to address the medial migration of the femoral head, and we have to try and fill up these bone grafts and give him a hip that looks like a primary total hip replacement. The basic principles of impaction grafting revolve around containment of the defect. So you can contain the defect either by using an augment, which is what my preference is in elderly people, or using a structural femoral allograft or autograft in these cases, which is what my preference is in younger people. Once you have contained the defect, you can prepare the bone chips and perform impaction grafting, and then you can put in either a cemented cup or a cementless cup if that's what your preference is. The technique of impaction grafting evolved from the Netherlands, from Tom Schloof's unit from Nijmegen. Then the Exeter group prepared the exchange system for impaction grafting. We have the Wrightington impaction bone grafting instrumentation. And then more recently, we have the Dupuy-Synthes AMT impaction system that we have contributed towards developing. We have a bone bank on site, so fresh frozen allograft for revision surgery. And in the case of an acetabulum fracture, we can use autograft, but that is freely available. The autograft or the allograft is then held within the bone vise. You take out the cartilage. I like to make these slices using a saw, and then I like to make my bone chips by manual preparation using a nibbler. A mixture of bone sizes varying from about 3 to 4 millimeters to about 6 to 7 millimeters would be ideal to get the best construct of impaction grafting. Once you've got these chips done, you can wash them. We tend to wash them about 3 or 4 times, and you remove the water. And this helps in removing the blood, the fat, and all the other debris that is present in the bone. It enhances the mechanical stability, and it gives you a dry bed of bone into which you can put cement. You can use a bone mill as well to prepare smaller chips, but I don't really like this for acetabular impaction grafting. This is better for femoral impaction grafting. And that's a bone defect within the acetabulum. You can fill the bone graft over there. And then these are impactors of various different sizes. The impaction has to be fairly vigorous. Obviously not so vigorous that you break the acetabulum, but vigorous enough that you get a stable construct. And once you have finished the impaction, you get this appearance of a cobblestone before you can cement in. This is a stable cobblestone appearance into which you can perform your cementation. In this particular case, there was a segmental defect that has been dealt with using an augment. And that's a picture of how a cobblestone appearance looks like. And once you have done that, you can perform cementation. So this was the case that I just showed you of the gentleman with the mal non-union following sepsis, and that his primary cemented total hip replacement with impaction grafting at about 8 years now. This year, I think he will come back for the 10-year follow-up. As can be seen, the columns were united, so I did not need any fixation, and I did not have to use any containment using a femoral head or any augment. So what is acute fix and replace? These are scenarios where you fix the acetabulum and you can replace at the same time. It is also called the combined hip procedure. We prefer to do it using a single approach and a single surgery. This helps in early mobilization and early weight bearing. You don't have to restore anatomic reduction, but just restoring the column stability should be enough. So this is a 65-year-old person who had a massive pulmonary embolism soon after his acetabulum fracture. So the hip was dislocated. He had to have an IVC filter. And by the time he came to me, it was already about 3.5 months. You can see that the posterior wall has remained displaced. The hip is subluxed. And basically the posterior wall is dead and you can't really use that. So what I did is used his own autograft as a structural graft. You can fashion it, fix it to the missing piece of the posterior superior wall, anchor it with K wires, and then that's a posterior column plate. So my philosophy is that if your structural graft is mainly superior, you can get away just with screws. But if it's posterior and superior, you get a lot of shear force. And I prefer to buttress it down with the help of a column plate and additional screws to give rotational stability. Then you ream into it, shape the acetabulum, put the impaction grafting, and that's your primary hip at 7 years. You wouldn't know looking at that X-ray necessarily that there was such a big defect. And in all these cases, cemented sockets work extremely well. The third case was that of an ununited fracture at 4 months. She came from another continent, and then she was referred to us. The surgeon there had tried to fix the acetabulum with these spider plates from the wrist. Obviously, it's not worked. We excluded infection, and then this was quite a challenging case. That was a CT scan that shows the residual displacement of the columns, and you will appreciate that at 4 to 5 months, it is very difficult to reduce and move these columns back. So the posterior wall and column fragment was basically a dead piece. It was a segmental defect, and it basically fell into my hands when I opened the hip. So I fixed it in vitro using that plate, and I felt it can work as a bone graft. I put it back into the acetabulum and then fixed it back. And the defect in the center, I reconstructed it with her autograft and plenty of bone. And you can see that is the first stage with column fixation, wall fixation, and bone grafting. And then I left it as a floppy or a pseudo hip or as a girdle stone for about 3 months. And then 3 months later, once it had fully healed, I went in to do the second stage total hip replacement using a hybrid construct. And she will also come to about 10 years now this year when she comes for follow-up. This is unfortunately a rare problem, but we do get it time to time. This usually happens during the use of an uncemented cup in osteoporotic bone, a big hammer or a sharp reamer. And you can see that even the early postoperative X-ray shows an intrapelvic cup. These are also challenging cases. You need to get CT angiograms done, rule out infection, make sure the blood vessels are not close to where the component is. And again, once the intrapelvic structures have been breached, I do prefer to do these as 2 stages because of the high risk of infection. You can see how close that screw is to the blood vessel. So a vascular surgeon is usually on standby. Stage 1, take everything out and put massive impaction bone grafting, in this case using an allograft that heals very nicely, and then go in at approximately 3 to 4 months. And that's a stage 2 primary THR. This lady will reach approximately 9 years of follow-up this year. So all the patients I have follow-up because we do follow up everything at Wrightington. So I can show you long-term results than just the early results. This is also another intraoperative periprosthetic fracture treated with impaction bone grafting. In this case, the bone was quite soft and osteoporotic, and the cup started prolapsing into the pelvis. And I've managed it with 3 femoral heads. Can you see how the bone graft has gone into the pelvis? We don't like to use a mesh. We just keep packing until it becomes solid. And then you can get rim fit using a trabecular metal cup. And this patient is now at 11 years coming for follow-up. So what have I learned doing all these cases? It is very important to assess the bone defect properly. The actual defect is often worse than the original defect. Bone grafting restores the biology and it turns back the clock. It allows the patient to have 1 more hip in the future. The technique is very demanding. It has to be done meticulously. So it is good if you learn it. Luckily, I was taught how to do the technique by someone who learned it in the Netherlands. And I've tried to sort of imitate that technique. You can use structural grafts or augments in containment. And that can give you good long-term results, even with cemented cups and impaction grafting in the post-acetabular fracture scenario. I've published my techniques in various book chapters and various articles, managing acetabular fractures in the elderly patients, how to reconstruct them, the acute fix and replace, as well as our impaction grafting technique. So those who are interested, I'm sure you'll find it in literature. All these papers are freely available. Thank you very much again for inviting me to be with you and share my experience.
Thank you, Nikhil. I think it's a wonderful explanation. What was very interesting was that cemented cups and impaction bone grafting in a situations which look quite difficult. So my first question will be that when you impact so much of graft where the part of the graft goes into the pelvis, are you worried about when the graft becomes solidified and any consequences of this too much of bone grafting inside the pelvis?
No, so far I've not had any secondary effects of that. You can see I put 3 femoral heads. I've got another patient where I put 5 femoral heads in. And
Right.
they just stop. We got a solid construct. Today I saw a follow-up of a cemented hip replacement that Rablevsky performed after acetabulum fractures using a 22 millimeter head. And she was 28 years of follow-up today following a fully cemented THR using a 22 millimeter head. I did not have enough time to put her x-rays onto the talk, but maybe in some future talk, I'll show you that. The results are very good. The important thing is, of course, this is the home of cement. We are trained how to do cemented hips well. We do all sorts of hips. We do hybrid hips and that. And what is important is not the type of the hip, but the impaction grafting, the replacement of the missing bone with new bone.
Right. And when you do it in the 2 stages, how many months you wait in between? The gap between the first and the second stage?
So the traditional orthopedic units are usually 6 weeks, 3 months. So I try to aim for 3 months. The pelvis, as we all know, is a very vascular structure. So we get very good healing by about 3 months. In one case, I had to wait for 8 or 9 months. And most of the others are trying to go in at 3 to 4 months.
So even in cases of the non-union, like one of the cases that you mentioned, or a widely displaced fractures, you wait within 3 months, you go in for the second stage.
That's right. I've got a collection. I think I've got about 14 non-unions now that I've managed with total hip replacement. The first 3 or 4 cases, I did them in 2 stage. And most of the latter cases I have done in a single stage. But that is probably more a reflection of my learning curve. When I was younger, 12, 13, 14 years ago, I didn't really know what to do with these cases. And a 2-stage philosophy just seemed safer. In the first stage, you get the columns together, ischial spine osteotomy, mobilize the columns, fix them, get them to heal. Because effectively, once you get them to heal, you have converted a pelvic discontinuity into a one-piece socket. And it's much easier to do a total hip replacement once the socket has healed. And I've used the same philosophy in managing pelvic discontinuity also in revision hip surgery. I think I've got about 40, 50 cases now, combination of 2-stage and 1-stage with bone grafting. So
well, that's a very interesting work, actually. Dr. Ramesh Sen, welcome.
Yes,
I know that you landed
to
Delhi now.
Yeah.
And you're on way to Vietnam.
Yes.
So anyone has any question to Dr. Nikhil Shah? Rakesh?
Yes, Ronan is waiting already for a question.
Yes, yes, Ronan, please.
Nikhil, I was very interested to know how do you actually prepare your fresh frozen allograft? Could you just tell us what sort of graft you use and what sort of preparation you use for these grafts? That's the first. And how do you actually wash them?
So you take a fresh frozen allograft, you defrost it. As soon as I start my case, my nurse will get it out of the bone bank. We put it in warm water. By that time, I finish my exposure and I'm ready to do it. And the graft has thawed. Once it is thawed, I train my fellow to do it. That's the first operation he does with me in revision surgery before he does anything else. We mount it on a bone vise. You take a saw and with very fine slices, you take all the cartilage off. Then you make slices and with a hand, we just nibble the pieces out to the size that I want. Then you put it in that sieve and we triple wash it just with normal saline that you use for injection. So normally these cases, I will have cell salvage with me. And for cell salvage, you will have some normal saline that is suitable for injection. With that, you just triple wash it, you dry it out. By that time, you've got your socket fully exposed and ready for impaction grafting. You dry it. I like to do a peroxide wash before I start impacting. Then you vigorously impact the graft in a contained socket. Once I'm happy with the impaction, I give a lot of pressure on it with my full body weight and you check for movement. Once you get a stable construct, a nice cobblestone appearance, you dry it again, and then you cement your cup into it. If you want to use an uncemented cup, that's fine. So long as you have good rim for osseointegration, you can put an uncemented cup and it works really well.
Thanks, Nikhil.
Hi, Nikhil. Subhranshu here.
Hi.
Yes, Subhranshu.
Do you do reverse rimming of the grafts or you just impact it?
You have touched a sensitive nerve there. Reverse rimming of the graft is not impaction grafting. I have got a very strong opinion on this. I don't think that should be called impaction grafting. You can call it bone grafting if you want, but that's not impaction grafting. If you want impaction grafting results, you have to impact the graft. And in fact, some of the earlier failures from Canada, if you read some of the earlier papers where they tried to modify the technique of impaction grafting and did reverse reaming, they were disasters. So no, I don't like reverse reaming, and I never do it.
So Nikhil, if I can ask you that, how much of the intact acetabulum you need to decide that this is the case where I can do the get away with the impaction grafting, because you have shown some very difficult cases which had a large defect.
So the size of the defect doesn't really decide that. You know, I will impaction graft every defect, small, big, large, because if you imagine revision surgery to be like constructing a building, how do you construct a building? You first lay the foundation. If you have a strong foundation, you can put anything on top. So for me, impaction grafting is the foundation of arthroplasty and revision surgery. Once I've got my foundation done, I can put a plate on it. I can put on a cemented cup on it. I can put an uncemented cup on it. I can put a custom acetabulum or a tri-flange on it. Doesn't matter what. But the foundation is bone grafting.
Yes, very right. The only issue remains, which may be a small question, that the impacted graft will take certain amount of time to be integrated to become the bone, to have the continuity. Until that time, the cemented cup is having the its continuity with the intact acetabulum which was there, the host intact acetabulum. So that, in your opinion, you very rightly said that it makes no difference that how big the defect is. Yeah.
Correct.
Mrinal, you had a question here.
Yeah.
Please.
Dr. Nikhil, I just wanted to ask, when would you like to protect your graft with a cage or a mesh, or do you don't believe in that philosophy at all?
I don't use a mesh at all, because over here we've always sort of been trained that meshes interfere with the revascularization of the graft that comes from intrapelvic into the hip joint. Secondly, if let's assume that this is going to fail or get infected, to try and take out an infected intrapelvic mesh is a nightmare, because the blood vessels get densely adherent to it. So I've never used a mesh. I don't need to use a mesh. If I need to plug a big hole, I'll take slices of the femoral head. And I'm sure you have read the Wrightington paper on management of protrusio hip, on how we use slices. And I'll pack the slices in the form of a network, and they support each other like the old Roman bridge. And you keep packing it and they become really firm. And then on top of that, you can pack the chips. And very rarely, if the bone defect is very good, I'll use two footings. So you take two augments, either trabecular metal or gription, you join them like a footing and they form like a big circle. And then you lay the circle on the floor and then you can pack on that.
What about the cages? You don't...
I've never done cages. I've taken out about 7 or 8 cages which have failed and converted them into a non-cage reconstruction. But I think cages break and they dislocate. Where the cages do work, I feel that you don't need them and there are other techniques to use. And where you really need the cage, which is to restore your continuity from the top half to the bottom half, I would prefer to use a posterior column plate and a percutaneous anterior column screw. And those extreme cases where there is nothing left, we use a tri-flange custom acetabulum, which is a bit like a cage, but which can ingrow. So in my practice, I have not used cages at all.
Dr. Hussain, you have a question, please?
Yeah, actually, I appreciate. Am I audible right now?
Yeah, very much.
Okay. So I have appreciation for the effort Nikhil has made it out and defining. Now, as an acetabular surgeon, we understand there are columns, there are spaces, and accordingly we do a reconstruction. In part of my fracture definitions, I use uncemented cups. So as Nikhil told that in superior and posterior defects, he told in superior defects, he will use a screw, and the posterior defects, he will use a plate along with it. I have been using both these things, but in superior, when I do an uncemented cup, because we don't get a superior purchase, so I tend to use now with the availability of augments. Superior, I use an augment. Posteriorly, because when you use a posterior defect, then I have got a ilium to hold on. So ilium, ischium, and pubis give me a reasonable stability, where the depending upon the posterior graft, how big or small it is, I may put a screw or I may put a plate. So in uncemented hips, I believe that in superiorly, probably a graft may not hold so well as this thing. I have used it also. Things are not, I had about 40 cases where I have used a screw with the plate for maintaining the graft there. But kind of when you are putting up a cup for the press fit over there, you feel doubt that tomorrow, if that graft is likely to give way, then my cup is likely to become loose. So that is the susceptibility. So because you use a kind of impaction grafting, so that has a different thing. So that is my concern about a superiorly using a graft.
So, sir, we have used
Nikhil, there are two things I think what Oxane is mentioning. The superiorly, if you are putting the graft, how confident you are? And posteriorly, do you always put a plate, or do you sometimes get away with just the one or two screws?
Yes.
So the first question first is the superior bone grafting. So we have a wealth of experience based on superior structural bone grafts from high dysplasia. And some of these high dysplastic patients are very short statured, and the biggest cup you can get into them is a 40 bantam uncemented cup. You can't even get a cemented cup into them unless you get a 38 by 22. And from that experience, we know that so long as you have fixed with 2 or 3 screws your superior graft, reamed into it, and then put an uncemented cup, the loaded portion of the graft incorporates, and the unloaded portion of the graft that is coming beyond the edge of the acetabulum, that will resorb over 5 to 6 years. And now we have data almost going on to 17 years of extremely well-functioning superior graft. The key, of course, is that your uncemented cup should be fixed really well to the remaining acetabulum. So in these cases, if I have to use a superior graft with an uncemented cup, I will put an anterior column screw through the cup. And again, as pelvic surgeons, we know how to put an anterior column screw through the cup. I will put some ischial screws, and you get your fixation at the bottom 2 ends. And then at the top bit, you try and get your fixations away from the superior bit where your graft is, or you can sometimes go through the graft. So I've not seen cup failure because of graft resorption. That's your first question. The second question is, when do I use a plate? So that's a bit of a judgment call. But if you imagine the right acetabulum, if your defect is starting from 10 o'clock and superiorly, you'll probably get away without a plate. If it's going to come below 10 o'clock, so 7 o'clock, 8 o'clock, 9 o'clock, 10 o'clock, I think I would just be on the safe side and I would put a plate on it. You know, it takes 15 minutes extra to do it. You're there. You've got a full exposure done. It doesn't take long to contour a plate and put it on. And I would rather be on the safe side and put one on.
Nikhil, regarding the first one that you explained, and if you're using a cementless cup, what you need is the good capture of the anterior and posterior walls. So if you have a good capture of the anterior and posterior walls, and even the superior defect is filled up with a graft and a screw, mostly the cementless cup will stay.
If you look at the failure of uncemented cups in your own practice or what is referred to you, you see what happens. People put one screw superiorly and the cup walks away always like that. It first debonds inferiorly and then it becomes vertical. So when I trained in Canada with Hugh Cameron in 2004, 2005, what he always taught me in revision surgery or primary surgery, if you're using an uncemented cup, we used to always put the inferior posterior screw first, and then if required, a superior screw. And then you get more circumferential ingrowth. You don't get only superior spot welding, and the longevity of your cup is dramatically improved. So I've just transferred those principles to acetabular surgery.
Yeah, that's very right. The inferior, anterior and posterior screws have become very important in these difficult cases. Yeah, I think we all will agree to that. Rakesh, you had the last question on this, I think.
Yeah, I think
then after we have your presentation.
Discussions going on. I want to make few questions and clear, and then few questions to ask. One, when we talk about impaction grafting, I think by definition, actually they go with cemented stuff. The impaction grafting and uncemented, whether it's a cup or a stem, don't seem to go very well in results. So if you're going into a technique where you're using impaction grafting, I think be prepared for a cemented cup. So that's one point to take home. The next one is the size of the things. So for femur, your things are going to be small, but for acetabulum, as Nikhil said, it has to be somewhere between 6 to 8 mm, or if there's smaller defect somewhere. And number two, you asked a question saying where would you put thing and where would you put the bulk one. So if you have a cavitary defect, you're going to put impaction grafting into that one. Whereas if you have a segmental defect, you would be putting one of these bulk allografts. And depending on your experience, you could either put, like Nikhil would put probably a cut head or an allograft, whereas Dr. Sen would put probably an augment. And I think now the fight between bulk allograft and augment also has been won by the actual augment groups. They are giving you immediate stability and they're going to last there forever. And they also get incorporated and probably in a more predictable way than a bulk allograft, because, we want the bulk allograft to take pressure when the hip is being put in. But many of them actually are under tension still because they are not holding on very well because of the size of defect we have. Number three, regarding plate or putting screws. So if you can put in screws and hold and you're happy with it, it's fine. But if sometimes you have fractures where you are actually trying to reduce them also, their plates would be a more superior thing than just screws. My question, Nikhil, to you is the fantastic technique which you showed, where you, I would say, depressurize your acetabulum so that the graft heals very well and let this floating hips lie on. I just want to ask you that you've come back after many months. Do you find bringing back the hip without too much of tension and getting the length right? But because your guys are quite adamant about the leg length equality also, where our patients are not that adamant, but they're still adamant. They are. Do you get the length right, or is there difficulty getting the leg length right?
So first question first. You mentioned that you can't use an impaction grafting with uncemented cups. So I would respectfully disagree. You can use impaction grafting with anything. And I showed 2 cases where I've used with an uncemented cup. So long as you have enough host bone left to contact the cup and get ingrowth, which usually comes from the rim, there's absolutely no problem. Impaction grafting works very well with uncemented cups. Second point, impaction grafting works very well with unloaded cups. Third point, yes, in the second stage, it is difficult to bring the cup down. So after I'd done my first 2 or 3 cases in 2006, I realized what was happening. So what I started doing is I started leaving a spacer of cement within the acetabulum and creating a supra-acetabular tongue of cement that I go for at least 1.5 inches in the supra-acetabular portion. What stops the hip from coming down is the abductors get adherent to the supraacetabular portion, and then to mobilize them, it bleeds quite a bit. But once you make this tongue of cement superiorly on the acetabulum all the way from 8 o'clock to 1 o'clock, then the abductors don't get adherent, and then you go in, you chip that spacer out, and your hip can come down quite nicely. And finally, leg length. Yes, I mean, it's a question of counseling the patient. Majority of these are quite serious injuries or serious cases, and they are more worried about pain relief and being able to walk again. So with good counseling, leg length does not seem to be that much of an issue for them. I don't even aim for equal leg lengths. The fact that the hip is solid and stable tends to be good enough for most people.
Right. And when do you start mobilizing these patients after the impaction bone grafting?
So mobilization is immediate, and that's decided by medical and anesthetic factors. Usually the day after the surgery, depending on how much stability I've got, I'll go for toe touch weight bearing or I'll go for partial weight bearing. And usually by 6 weeks, they're fully weight bearing.
All right. So no protection from weight bearing, even if you have a large defect.
No, in fact, you want physiological loading, don't you, for the bone graft to remodel using Wolff's law. And to be honest, I think non-weight bearing is a bit of a myth, because I don't think patients actually listen to us. And when you don't load the hip and you hold your hip floating, your joint reaction force is actually higher than if you allow them to toe touch. So I don't think you can ever reach a status where a hip is not loaded at all.
Yeah, I think I agree on this. I think all of us will agree on this. Then we go on. I think that we had
Rajiv,
a wonderful
just one
discussion.
question.
The last one. Yeah.
Rajiv, just of the other faculties, how many of the other faculties have got experience with cemented hips in acetabular fractures or in general for these sort of cases?
I think most of us here are using the cementless cups, if I'm right.
I just want to hear from anybody else who's been using.
No, I use both of them depending upon case-to-case basis. I'll show in my talk also where I feel it's comfortable to use a cemented one as compared to an uncemented one.
We have Vivek here. Vivek, are you there, Vivek?
I use cemented cups whenever the host bone contact is less than 40%.
Yes.
If it is more than 40%, preferably I use nowadays trabecular metal cups, the Gripson cups which are there available. So if it's less than 40%, I prefer cemented cup.
I think Subhanshu's point is very valid, Rajiv.
Anil, are you there?
Rajiv?
Okay. Yeah.
Subhanshu's point is very valid. That if you have a contained acetabulum, like you have the whole acetabulum, you can go with any cup you want, even cemented. Or when you have really deficient acetabulum, is exactly what Subhanshu. That's again a place where cemented will score over unccemented cup.
Yes.
When you're talking about almost non-existent acetabulums. So again, I think we have to fall back on uncemented probably, but the results probably are not going to be great on a long-term basis on that one.
No, but in impaction grafting, even those scenarios, the results are reasonably good. When you don't have a good containment of the uncemented cup, cemented with impaction grafting does give a better result.
I agree. In the literature with impaction grafting, generally it's the cemented cups which have got good results.
Yes.
Let us hear from Anil. Anil, are you there?
Yes, Rajiv, thank you.
Yes. What's your opinion? I know that you do a lot of such cases.
No, just a handful. And in fact, we did, my concern is only very simple, I think, to Dr. Ramesh Sen and Dr. Rakesh and to Nikhil as well. Basically, when you use a cemented cup coupled with an allograft in the background of a cup cage construct, or in terms of a bulk allograft, or in terms of morselized allograft, my question is not the immediate outcome. Yes, Nikhil said you need physiological loading, you need scaffold, everything. My question, and in fact we did publish an article also, there is always a risk of delayed collapse. We are talking about delay in terms of the fact that at 7 years, 8 years. So that is our worry with allograft with cement. So that I don't know what Nikhil's take or even the rest of the panelists' take on that is.
So all the cases I showed you had at least 9 to 10 years follow-up. I think that should answer your question.
Okay, so because we've had some of having delayed lysis, there I've got a fair series which go on to have a long-term follow-up, but they are unpredictable. I'm sure your cases, yes, you have 9 to 10 years, but I'm not sure it's as predictable as because even Gross and the rest have moved away from the actual traditional allograft with the cup cage, if I'm not mistaken. So I'm just drawing a similar scenario. I'm not sure what.
Yeah, I think Anil, it is very technique dependent, and we do head grafts right, left, and center. We start doing them in primaries in dysplastic hips. Nowadays, we have coined a term called COVID hips, where you see these hip replacements after COVID, and the acetabulum has been destroyed. And so long as you can get them nicely fixed and flush with the ilium, where the edge of the cup and the graft is flush, they work extremely well. I think the collapse probably is down to either inadequate fixation or too large a graft that cannot ingrow. There has to be a limit on the size of the graft. And so far, I've not really seen a defect where I felt that the defect is too big for a head graft to work, and you have to have a cup cage. So with augments, plates, bone grafting, and if required, a trabecular metal shell, I've been able to reconstruct most defects. And if they're that severe, I'll just stage it. I'll do it in 2 stages. In the first stage, you solve one problem, and you come back and you deal with the other problem in the second stage.
Right. Thank you, Nikhil. I think the last one, I'll just speak up on behalf of Saqib Yassin, who has put a question on the chat, and Shubhranshu has also answered it. Saqib's question is simple, that allografts are not available to most of us, and trabecular augments are too costly. So is there some affordable and readily available solution that we can give?
Well, femoral head autograft is free of charge.
Yeah.
You can use that in primary cases.
In
revision cases, I think it's got to be one or the other. It's got to be either an allograft from a bone bank or an augment.
Right. Thank you so much, Nikhil. I think it initiated a very good discussion. And I hope that you will be with us throughout this webinar. The next talk is Dr. Ramesh Sen.
I've got 5 patients waiting, so I'll have to take your leave.
Right, Nikhil, thank you so much for being with us.
I'll join back.
Right. Rakesh, you had some
Nikhil.
quick question.
Yeah,
Just
so
one sentence, please.
This is what Dr. Saqib has asked a question about. Either I agree that augments are quite expensive, and sometimes because of this COVID situation, many times they're not even available. You ask the company and they'll say, I'll get it from there, I'll get it from there, and ultimately you don't get it. Bone banks are not that difficult if you really put your head to it and just do a little bit of planning. I did just yesterday one. We don't have a bone bank in Calcutta.
So
I
we'll have
a
next webinar on the bone banking
It's
and
very
bone
important, yeah.
grafting maybe. That's a very important subject. Thank you, Nikhil, for being with us from a busy schedule. Thank you so much.
See you then. Bye-bye.
Dr. Sain will be speaking on next talk, case presentation on osseous defects in post-acetabular fractures.
Yeah,
Dr. Sain.
thank you. Basically, I'm taking it what Nikhil said it out, that as an acetabular surgeon, we understand there is a pattern of displacements. And when you're reconstructing that pattern, there are specific kind of reconstructions. And even the defects, whenever they remain, they are of a very specific type. And one of the most important thing which determine is the bone defect. Out of the experience which we have built up in last 13, 14 years, we had in India reasonable number of hips which have been neglected as compared to reconstructed, almost 50%. And in that 50% of the cases, when we start defining them in Peprosky, there is a way in which it is a revision scenario. Likewise, in American Academy classification, it is a revision scenario. And out of all the publications, most often the classification has been Peprosky and American Academy. But both these classifications say they are not meant for post-traumatic revisions. That's very clear from even their narrations. In that scenario, if we find out a defect between a acetabular fracture defect vis-a-vis a revision scenario, there are reasonable number of differences which happen. So if you consider all these defects, the classical definitions do not help us. So we proposed a classification last year, and then we defined it as per the lateral classification and displacements. With the kind of this thing, then what we did, 99 AP radiographs with those defects, we sent to 10 surgeons who are in India, who are experienced, and we shared with them the protocol of evaluating them and finding what they will see about the defect vis-a-vis a Peprosky defect, and ask them to comment out how they will do surgery. And they had more than 5 years of experience, and 7 had more than 50 cases of post-acetabular reconstructions. We asked them to define according to Peprosky and according to the new classification. And you see here, what all these 10 people, many of them are here, what then they contributed, we analyzed the results. If you look at inter-observer reliability with the coefficient of Krippendorff, we had Peprosky 0.3.9, while for the new classification it was 0.7.2. While as far as the agreement is concerned, we had excellent agreement in 69 in the new classification 3, and likewise poor percentage was very high with Peprosky as compared to this. So there is a major difference in understanding the fractures which happen and the displacement which happen. Then we asked them to do, the second part was how they will reconstruct it. And you can very well say, for a specific kind of a defect, most of the surgeons agreed on a specific reconstruction. It's not that it is uniformly displaced. So it depended upon, it linked was with the type of the defect. Now I'll go with these 10 cases fastly. One is type 1 defect, when there is a simple fracture which has basically led to the primary, where there is a loosening out after the acetabular reconstruction. So here it's just like a basic thing. So there is not much, and where we do a standard reconstruction, not an issue. This is also another type 1. But it is type 2, which is very common. Now, this is not a common scenario in a revision situation. It is a very common scenario in acetabular where the posterior wall is gone, and which Nikhil was just talking about it also. So here we need a reconstruction, and then we use a plate, as he told also, and then we can put an uncemented graft. If the femur head is destroyed, if we don't have a bone, as was just talked about it, our next solution remains the augments. And in this area, the augments can help us in getting a proper cupping to the situation, and then this can give us an outcome. While on this other side, if we go to type 3, when the posterior column is fractured, it may be malunited or it may have a frank non-union. So there are two scenarios, A and B. If this is malunited, again, the reconstruction of the column is more important. But if there is a defect, It is not united. And then in that kind of a scenario, you will have to reconstruct a column for the cup to settle down. And this reconstruction requires a reasonable amount of a bone into the area. As Nikhil also showed in one of the cases, a reconstruction of the posterior column and then the placement of the cup. And then there is a subsequent follow-up. If it is a non-union, you can see it here, you see a non-union also. Again, it needs the stability for that non-union to go on, and then only the cup can be put in this scenario. Then is the transverse. Transverse fracture is like a pelvic discontinuity. If it's a malunion, it is stabilized, then we don't have any issue. If it's a non-union, it becomes a pelvic discontinuity kind of thing. Now here, there is a link between the proxy ilium and ischium, and here any cup after the fixation can work, and here I'm showing. But if it is a non-union, it's a kind of a pelvic discontinuity, as the classical management has been with the cup cage construct also. So here in this case also, we can do similar kind of a stabilization first, as Nikhil told, and thereafter reconstruction, where we may use any of the options available. Here is a very old case done somewhere where the initial fixation was done, that failed, and a simple cup was put in, which also failed again. So this is a very old case when octopus cage was available, which Nikhil was talking about it. This is a cup where we used to have a bone graft along with the cage holding an uncemented fixation, and this is the subsequent outcome. And the last is anterior column injuries, when you don't have an anterior support, it is gone. And this is situation where we have been using a lot of cancellous graft as an impaction grafting, and where there is a way in. Nikhil told he is using larger sleeves also, but sometimes the defects are even larger. So we have used a mesh in to support that graft area. It did an impaction grafting. Another case where we used a small mesh also, and thereafter that sleever which Nikhil told was, we put in that sleever also into these areas, and then we did a impaction grafting and a cemented. Another case with the same kind of a cement holding the mesh with the screw in a proper position. So in these types, depending on the types, we have made this kind of a definition, and this is all with the perception of all the surgeon, and this is what we have published now, because there is no classification across the world available for defects which are caused by acetabulum fracture. So we thought if we look these fractures with the proper classification, we do have a certain way of management, as Nikhil has already told us. So this is what I feel, it can be a specific way in which we have a specific designs. Thank you.
Thank you, Dr. Ramesh. I think this is an excellent explanation of the posterior wall defects. Ronan, do you have any question to Dr. Sen? Or any other faculty?
Ronan, you are muted.
Rakesh.
Ronan, you're muted. Rajiv, actually, me and Dr. Sen have discussed this classification inside out. I have been one of those 10 people. So I really don't have a question. I really admire this classification. I just feel we should use this more and more as a group.
Right.
I would tend to agree with Rakesh that if we could sort of spread the word, so to speak, within the IAA, would definitely help in decision making, as Dr. Ramesh Sen has said. If we could possibly have a sort of an algorithm worked out and make it as short as possible, I think it would help all of us in decision making in our day-to-day practice.
Yeah, one of the slide had that algorithm.
I think these are the difficult cases, and if all those who have the long follow-ups, I think we can join hands together and put it up together. That's a very good
just
idea.
the classification and just the algorithm, I think we can just 2 slides, even as a PPT or as a PDF, we can send that to the whole groups.
I think that would definitely help.
Because it's been published now, so there's nothing to
exactly.
Yes.
Yeah, it's in IJOA. Our journal, it's as a original article, it's been published.
Right. So if there is no other question on this, Rakesh, I'll request you to share your screen.
Excellent job.
And
Thank you.
speak on again the neglected posterior wall fractures.
I think we can discuss more the cases. Yeah.
Right. Surely, please.
So I think my brief today is to talk about the Rajiv, am I audible and visible?
Yes, very much there.
Yeah, so it's about the arthroplasty in neglected posterior wall fractures. So I think what really contributes a posterior wall, basically it's the articular surface from the posterior surface and then going on to the entire column. So the exact area where the posterior wall and posterior column actually merge is sometimes very difficult to decide. But I think if you look at the column, which seems to be flat, and then you have this curved area, which probably is the wall. But most fractures really don't follow this sort of an algorithm, and they can actually take a bit of column, or you can remain actually intra-wall fracture itself. It's not very small incidence. It's actually 20% of these fractures of the whole acetabular fractures are the posterior wall, and many times they have taken the column also. Now, which part of the wall has been fractured sometimes actually will guide you as to what treatment you do. And there are times when you have to operate even acutely on these fractures. If your hip joint is unstable, if it is incongruent, or if there is something preventing the reductions, or if there is interarticular fragment, femoral head regions, sciatic nerve lesions. Now, I'm not trying to illustrate all these areas, but one of the most important is the acetabular impaction. Now, if you have one or few of these, then you can actually go ahead with the primary surgery where you put the head back in place, reconstructed those defects which you had. But if you have like a head which is in pieces, or head which is really scratched very badly with severe impaction, slightly older population, delayed presentations, then you are slowly moving more and more into actually the reconstruction of these fractures. So AOS will classify them as segmental, and if you just saw the Dr. Sain's classification, that will be the type 2 defects for them. So I think the way we are going to approach this, unfortunately, according to literature, will be by using the hemispherical implants with or without screws. So in predominant cases of routine THRs, we manage them without screws. But I think here we probably should put some screws in just to get those extra stability. So this is our case now. This is a young in 40s patient who actually fell from his bike in an RTA about 4 to 5 months ago. Now, it was originally missed actually, this injury, and but he was put on bed rest because of the severe pain, and then he was allowed to actually walk on this. So he walked on this for about 4 months, and when he presented to us, he was in severe pain. Even all his hip movements were so painful. And then we did a CT scan for him just to find exactly how bad the posterior wall fracture was, which was seen actually on the presenting X-rays. And if you look now, there is combination, and the fracture starts all the way superior and actually has come all the way to the ischial tuberosity. And now there is a bit of defect also in this. Now, if you look very carefully, and particularly in the 2D scans also, you can see that there is scratching of the head also in this. So on one hand, I wanted to save because this guy is in very early 40s, but in this case, I was prepared for a THR. So when we opened this up, we realized that there was impaction, there was a very delayed presentation, and the head was really scratched. So we went ahead. So the principle for with this will be now, because you have an acetabular wall, which you can actually fill back, the wall itself you can hold on back. So you use that wall back in place, hold that with the plate, and the rest of the cavity which you have now, you can put an uncemented cup. As I said, we would use screws here to give that extra stability, but don't rely on the screws itself. Now, sometimes they present even later. Sometimes they have injuries which go up even more. So this is again a lady which was treated with traction for 3 months. So here it was identified, treated, and then mobilized with walker. When she came to us, she was on actually a wheelchair, and 6 months later, and look at her injury. So this was actually a transverse with posterior wall. So by this time, the transverse element to a large extent has healed, not fully united yet. But if you see the head, it has been pushing on the superior, and now you have a very oblong defect. And in this ones, when we did CT scans, we were prepared for the worst. And so hence in this one, what you need is the whole buttress part of the wall is missing. So it's just not a small wall augment you can get away in here. You need to build up her whole posterior buttress also along with that. And still the posterior column was not yet fully united. And as Dr. Sain's classification, you have to stabilize because these are still almost like pelvic discontinuities. So you got to bring them either by cup cage constant, you give stability, or you fix the posterior column and you give that stability to this patient. And then fill the defects, which was a segmental part, by either an augment or by a buttress augments. And then these ones I would actually wait there a bit later when I'm very happy. So it would be about 6 weeks, 2 months later. So that's her mobility. So what we've learned lessons from the posterior wall component is that you should still try and fix them because most of them will be fixable, but be ready to replace in cases particularly presenting late. So if they're late presentations, then I think you should have very low threshold for fixation. along with that, if you have head scratching, along with that, if you have marginal impactions, and things which may look unstable may become stable, or sometimes you can make them stable, or sometimes the fracture on X-rays may look stable, but when you're reaming, suddenly it becomes unstable. So be prepared for both the scenarios. And I think here, and you've heard from Nikhil's talk and Dr. Sen's talk, that we probably want to put fixations even on the ischial or the pubic side. So you need multi-hole cups, but you need the screws which are actually more on periphery rather than just having just multiple screws. And the cups to be used, actually, the go-to cups here would be the highly porous cups. So it would be like the Gription cup if you are from a Depot table, or the Continuum cups which are from the Zimmer table. So, and screws, I said, are quite often required, but do not rely on the screws for the primary purpose of stability. And I think more and more cases which actually are even dislocated for a long time will have a repeat higher incidence of dislocation. So these cases you might want to move on to dual mobility cups also. So that's about it from me. Thank you very much.
Thank you so much, Rakesh. Again, a wonderful presentation. And I think let us keep running the discussion for the end of the webinar, all the presentations. Is it okay?
I think that makes sense.
Yeah.
I think it will save a lot of time. Yeah.
Yeah. Thank you so much. The next talk will be our friend Krishna Kiran and Dr. Vinay Kishore. Vinay, are you there? Dr. Vinay?
Yeah, Vinay is here.
Hello.
Oh, yes, Vinay. Can you share your screen?
Hi, good evening, sir. Yeah.
So Dr. Vinay Kishore will be presenting on behalf of Dr. Krishna Kiran from Hyderabad. He'll be speaking on, please share your screen, Vinay.
Yes, sir.
He'll be speaking on arthroplasty in non-union posterior column fractures, which again will be in continuation of the same difficult topic. In the meantime, when Vinay is sharing the screen, if there is any question to Dr. Rakesh or Dr. Ramesh Singh.
A very important point, which
Yes, Dr. Sen.
Yeah, very important point which Rakesh has made it up is about the posterior column and involvement, because incidentally this is most common defect which we encounter in India, because most of the patients come with the late kind of a scenario. Now, usually we can have 3-point stability of up part is there in most of the cases. It's a posterior wall, so ilium remains, ischium remains, pubis remains there. So primary stability remains there, and now it is the amount of posterior wall, as Rakesh has said it about, where we need to build it up. And once we get this multi-hole cup and we have a screw down into the pubis and into the ischium, we are quite comfortable with getting that stability and that kind of a outcome. So that is very well there. Now posterior wall.
Very right. Dr. Sen, 1 minute. Dr. Vinay Kishore, since in the meantime when we are discussing, please share your screen. I don't want him to be confused that we are having the discussion.
No, we are just waiting for him to be there. Yeah.
Right. Vinay, are you there?
Or we can go ahead with the next presentation.
I'm here, but I'm having difficulty sharing the PowerPoint.
No problem. No problem. Vinay, we'll just have the next talk, and then maybe you can share your screen. Since Mrinal, can I request you to share your screen? Dr. Mrinal Sharma from Delhi NCR will be speaking on arthroplasty revision in post-acetabular fractures, which again is a notch higher complication.
Can you see my screen, sir?
Yes, we can. Yeah.
Okay, so I'll be speaking on revision of a total hip in a failed total hip arthroplasty post-acetabular fracture. So this is a rare complication which usually we see, but it can happen for reasons being that the primary stability was not achieved during the surgery, the columns were left unstable, or the fragments were more than 20 millimeters displaced, which were not actually reduced or fixed. The bone defects may have been left untackled, And it is commonly seen the failures are more common in the transverse types, the T types, the anterior and posterior hemitransverse types, and the ones with both column fractures. So how to avoid these failures? The best thing is when you do a total hip arthroplasty, you build up the bone defects, you reconstruct the columns, and try and use a multi-hole porous coated cup with and getting a screw purchase at least in 4 columns. 4 screws should minimum be used in these cases, especially in the sciatic buttress, the gluteal buttress, the superior pubic rami, and the ischial buttress. So if you put these 4 screws, which the ones in the pubic rami are called the kickstand screws, which actually help in reducing the abduction failures. So these are very important. This is how you can reduce these failures. But sometimes these cases do fail. And the problems when you revise this is the distorted anatomy, scarring, soft tissue, fibrosis, possible necrosis of the bone fragments, and hardware problems. There might be plates, hindering your placement of the cups in the proper positioning. The bone defects, the malunions, and obviously sometimes a chronic pelvic discontinuity might be seen. Now, the first thing is infection needs to be ruled out. It has been shown that almost 27% of these hips which would fail post-total hip arthroplasty in an acetabular fracture might be infected. So we need to do aspiration, and the counts need to be within range before you go for a total hip, or you stage it in 2 stages. Perioperative workup needs to be with pelvis, both hips, X-ray, Jude views, CT scans, especially in scenarios where you might encounter pelvic discontinuity or the column is compromised. A CT angio for cases where the pelvis or the cup has migrated into the pelvis, and ultrasound Doppler for patients who might have been bedridden for a long time with suspected DVTs. So this is the case I'm going to present, which came with this is the X-rays. She had a both column transverse fracture, 59-year female, and you can see the head is also indented, it's impacted. This is the X-ray she had when she went to a surgeon who operated her after 5 to 6 days, and they did the anterior column plating. After 2 days, 2 to 3 days, the posterior column plating was also done. But they still missed the fracture in the neck of femur. You can see the head was impacted and the neck was also, damaged. So obviously this was bound to fail. So this patient underwent a total hip arthroplasty almost after 6 months. And this is what the surgeon had done. He used a dual mobility, but you can see the cup is vertical and it is retroverted on the CT scans. And ultimately it was bound to fail. And you can see 3 months down the line, the cup is failing in abduction because the surgeon probably thought that the dual mobility is the panacea for all kinds of malpositionings, but that is not the case every time. There was no kickstand screw, so that is why probably the cup started to fail in abduction and it got peeled off from the inferior side. Another 6 months later, this is how the patient presents. So it's a frank pelvic discontinuity now. The cup is almost, toppled, and the patient is having extreme pain. And this is a case for revision now. Infection needs to be ruled out. The options being multi-hole porous coated cups, custom flange cups, cup cage construct because it was a pelvic discontinuity, distraction techniques with the gription jumbo cups and augments, or a cage and allograft. Considering her age and the socioeconomic status and whatever I could get at that time, I opened up. This was the dual mobility which I removed. You can see that there is a lot of defect, and there was, the columns were pretty okay, but there was discontinuity, mobility at the junction of the ilium and the ischiopubis. And ultimately, I cleaned the discontinuity. I, removed the fibrous tissue, did impaction grafting, and this is with the allograft I could attain from another hospital, and I used a gap 2 cage. Now, when you use these cages, it is very important that you put the bone graft in the bed, and there should be some bone graft which should be placed inside the floor of the cage also, so that once that bone graft incorporates, that cage is stabilized. So that will help in reducing the failures. Another thing is that when you use screws, you must use screws through the cages on the top of the flanges, superiorly in the supraacetabular region, as well as use screws in the pubis and the ischium if you can through the cages. Another thing to reduce failures in such cases is to unitize these screws with the supraacetabular bone using some bone graft and also cementing that part. So this is what I did ultimately, and I used a large diameter head. This is the immediate post-op. The plates which were hindering, the part of those were removed. And this is 3 months follow-up, and this is almost 4 years follow-up of the patient with impaction grafting, and the discontinuity has healed and the patient is mobilizing well. So this is one way of tackling revisions in such scenarios. Another way, another case, 66-year female, 6 months after a total hip, you can see this, the gap was left untouched by the surgeon, probably not grafted, the cemented cup failed. And you can see the cup is grossly loose. I opened and the cup, the acetabulum cup had already been, it was loose, so it was easily pulled out. You can see the huge defect. So I identified the TAL, did identify the non-union site, removed the fibrous tissue, did some bone grafting there, did impaction, reaming, and the trialing. And this is the graft which was put. And I used a multi-hole gription revision cup with peripheral screws also. And this was the final cup placement, and it was stable. And you can see that the hip has been reconstructed and it was grafted well. So the things to remember in revisions in such scenarios is that you must be able to restore the bony anatomy and the column support, at least get an anterior-posterior capture and build up the bone defects. You might use bone grafts if you have access to allografts, or augments are a good, option, and must achieve stability on table, whatever way you can. It is preferable to use multi-hole gription or highly porous coated multi-hole cups with preferably 4 to 5 screws to stabilize. Thank you.
Thank you, Mrinal. I think we'll have an interesting discussion at the end of all case presentations. And now, since Vinay is ready with his talk, Vinay, can you please share your screen now?
Unmute, yes. Now share.
Yes, we can see your screen, Vinay.
Okay, sir.
Thank you. Please go on.
Yeah. First of all, apologies for 2 things. Dr. Krishna is away traveling, and for the inability to share my screen earlier. I was trying to do it from my phone. Am I audible?
Yes, please.
Okay. So yeah, I'm here to present Dr. Kiran's case. This we used a distraction technique in a chronic pelvic discontinuity case. Actually, this is an interesting case. Patient who has someone who has been with us for a few years, more than a few years actually. So just a second, sir. Yeah. So this is a 47-year-old man who was multiply injured, a case of polytrauma, and the index surgery was done somewhere else. And he presented to us for the first time 12 months after the injury with this X-ray. And he had other injuries apart from the acetabulum fracture, both tibia, one radius, one forearm, one humerus as well. So this is the main complaint he came us with pain in the right hip, the operated hip, and his ESR-CRP was elevated. As we can see, an attempt at fixation was done, but currently, symptoms and all, it was definitely a case of infected hip joint. So the first surgery was done by us. We put a cement spacer in and a PICC line in for local delivery of antibiotics, and we asked him to come back after his inflammatory parameters had settled. And in the meantime, we had done some preoperative planning with 3D printing. And this is what came out from the CT scan images. As you can see, it is a huge defect with absolutely no medial wall at all. Yeah. Sorry. So this was after everything settled down, after all its inflammatory parameters settled down, we went for hip arthroplasty using an augment and a big cup. 10 months in 2004, 10 months later, he came back with abduction failure of the construct of the acetabular construct. As you can clearly see, the acetabular construct was failing in abduction. So this is 10 months after the surgery. As you can clearly see, the whole construct has failed in abduction. So this was in 2014-15 when we probably started doing all this complex revision. So what we did was one of the popular choices. We did a cup cage construct again, and this is the 7 years follow-up. So while we were doing the cup cage construct, we did some inflammatory parameters, and the values were near normal, maybe slightly elevated. But the intraoperative culture specimens that we sent grew pseudomonas. Now it was a real downer for us when we got the culture report. And but the patient was asymptomatic for 7 long years. And after 7 years, the infection flared up again, and the whole construct came loose. So what do we do now? And we were stuck in a very difficult position. So again, we went in with great difficulty. We managed to get everything out, except for 2 screws which were remaining from the index surgery, the acetabular fixation. We put a cement spacer in, and as you can see, there is a major defect there. And this is the scan. So what we did then, we actually used the distraction technique because this is a chronic pelvic discontinuity, and as the new acetabular defect classification, this is a posterior column non-union. So we used a TMR shell, oversized TMR shell. We distracted it, and we used an augment as well. And we unitized this whole construct with cement. Now, the very important technique is you have to unitize the whole construct, otherwise it will again fail. And after having learned from the abduction failure from the previous surgery, we put these screws into the superior pubic ramus. What we do is we take a TMR cup, take the metal shell out, metal rim out, and we drill holes with a diamond drill bit into the periphery of the TMR shell. And we put the stick and screw in now into either the ischium if possible or into the superior pubic ramus. So this is where the patient is now. And this is 1 year, I think 11 months follow-up. So yeah, that is the case. We wanted to see that the distraction technique is a useful bailout technique in very severe cases of pelvic discontinuity. So yeah. So that is my presentation today.
Thank you, Vinay. I think it's again another very, very good case. And we'll be discussing in the discussion time about your distraction technique and the screw fixation in the ischial screw fixation.
Yes.
Now, can you please unshare your screen?
Yes.
Can you please, can you see my screen, please?
Yes, sir. We can see your screen.
Yes. Thank you so much. So next case, I'll show the total hip arthroplasty in pelvic dehiscence. We know the radiological landmarks, and we see that when all the columns are lost, and you have a situation like this, what you see here, now it's a real challenge how to manage it in an easy way. Because we can see on the CT scan, we can see on the X-ray that the head has gone inside. This massive trauma has made the pelvis, almost disrupted the whole pelvis. And how to manage it in an easy way? That's what surgical video. The columns are lost. There is a floor. There is a large defect. That's the posterior column under my finger. Some of the small fragments were
intact. We can see that there is a large defect here. And unless you unitize the two segments of the pelvis, no fixation is going to work. Distraction technique could be one of the good way. See that the trauma surgeons are well aware about this kind of a plate fixation, fixing the ilium and the ischium. Having the strong fixation of this plate and at least 2 or 3 screws proximally and 2 distally will be important, so that the place is stabilized well, and at least the one column is strongly fixed. And this plate has to be fixing on the bone, and making sure that you are not damaging the nerve, which will be very close by. Because since it's a primary hip, it is very easy to use the bone graft from the femoral head. And as Nikhil has rightly shown, we also do almost similar way. We slice off the head, and these slices can be made into the smaller slices, and can be fixed into the floor and into the pelvis, and then impacted strongly by repeatedly putting the one by one the bone grafts and impacting them with a impactor slowly, and then again put more graft, then again impact, put more graft and impact. Now that way, the fixation of the graft will be to some extent good in the acetabulum, fractured acetabulum. Then in this case, we have used after fixing the plate and bone graft, we have used the cage. And that's how when you use the cage, you have to have the space for the superior flanges to go into the ilium, and also the inferior hook to hold the bone strongly in the inferior wall. So once you do it well, unless this inferior hook is fixed well and placed in a stronger position, the cage will not have a reliable result. And once you fix this hinge, then you can impact it slowly, and then ensure that there are enough number of screws are fixed in the superior portion of the cage, and also through the posterior wall or the pubic area. At least 1 or 2 screws should be fixed. See that the screws are being fixed, multiple screws are being fixed into the cage. And once you fix all these cages, the cage really becomes, the whole construct becomes very strong. And only when the construct is strong, then you can start going on to the next step. And just go on. And that's what the remaining graft that you have, you can put the slices in the back in whatever area is left. And then you see that how strongly the cage is fixed now. You can see after putting the lot of strength, the cage stability is clearly visible. And the next step is to cement the cup. You take the cement, and when it is sticky, it becomes non-sticky. Then you put the ball of the cement into the cage and impact it, push it with the hand, with the pusher, and then fix the cemented cup in position. And then you have to reduce the head. And then you have a reasonably and stable construct. Now, this kind of a construct can be very useful, especially in an elderly patient. I think it's a very good way of fixing this kind of a pelvic discontinuity. Thank you so much. Now, the next, I will request Shubhranshu to speak on his topic of traumatically deformed pelvis. Yeah.
Okay. The screen is visible?
Yes, Shubhranshu, it's visible.
Yeah. Thank you, Dr. Sen sir and Dr. Ronan and Dr. Rajiv for this opportunity. So I'll be talking about a case. I'll be presenting a case of doing total hip in case of chronic pelvic diastasis. So here is my case. Is a 58 years old female, hypertensive, with little obese, BMI 27.1. Sustained a trauma to the right hip and pelvis about 5 years back. That is way back in 2017 or 18, something like that. Initially, he was fixed with an external fixator in Gujarat. Then he traveled to Mumbai And after that, the external fixator was removed, and there is a posterior column plating of acetabular fracture. One sacral ala fracture was there, for which a screw fixation was done. And there was also associated femoral sap fracture, for which a long PFN was done. So with all these elements in situ, the patient presented to us, and we don't have the earlier X-rays, unfortunately. But in the first sitting, we removed the nail and the sacral screw in 2000. Those are removed, not 2002, 2020. Sorry. And then we discharged the patient, and but patient had pain and difficulty in walking. On examination, when he presented to us afterwards, the hip was mobile, and there was shortening of about 1 inch, and there was a foot drop which was there from the beginning of the injury. ESR 22, CRP 11.8, and that is the X-ray which is showing pelvis diastasis.
ग्लास एंगेज हो जाएगा, कप में रख सकते हैं.
Dr. Sanjay Kumar, could you please mute yourself?
No,
that is the AP view of the pelvis. So we took little 20-degree internal rotation view to see the obturator foramen clearly in order to assess the cup. So the pelvic diastasis part is about 5 centimeters we measured. So this is 5 years old diastasis. So what to do now? 1 stage, 2 stage, take out that plate also from the acetabular side, and second stage, do the surgery totally replacement. What is the planning? What is the implant selection and fixation? And what is the bearing surface? Anyone would like to comment?
Yeah, I think it's a. I would prefer a 1 stage in this kind of a situation.
And what is your planning for surgery?
The first should be the removal of the plate as much as possible.
Yeah.
Removing all the screws. Maybe one of the free screw may be difficult to remove, but that should be the first planning. This the femur is proximally ridden, so probably there will be requirement of some kind of a release. And there seems to be significant shortening in this particular case.
About 1 inch, clinically 1 inch shortening.
Okay, yeah, it looks like, yeah. And then there is the pelvis is in a badly deformed shape. How stable was the pelvis?
Yeah, pelvis was stable.
All right.
No issue with pelvis.
Then my take will be to a cup cage construct in this.
Okay.
That will be the best way.
Yeah.
That
will be more reliable, actually. Yeah.
Yeah, sensor.
Yeah, there are 2 things over here. First is the pelvic opening up. If we take a axial cut CT and we are able to define out how much is the version change, because now in this scenario, with the kind of obliquity, making it a retroverted situations, we will have to take that care. Second part is the pelvis being open, but most of these cases in a late cases become reasonably stable enough. The only difference is, while in a closed pelvis, in a kind of a contained pelvis, the forces are distributed reasonably well to back as well as front. Now all these forces are going backwards. So we will have to reorientate our cup in the direction of the back, and then accordingly we will have to put that version. Sometime with this kind of a cup which is externally, which has rotated backward, that version will be very difficult thing to achieve. So personally, I feel that we'll have to have a reasonable amount of a augmentation posteriorly, so that we can have the proper orientation for the cup. Otherwise, chances of dislocation will remain in this kind of a scenario. We have seen some cases of oblique displacement of the pelvis also. In that case, our inclination has to change. Likewise, in these cases, when we do, our version has to change, in addition to whatever is already being discussed.
I agree with you, Hussain.
Yeah.
Because the so much of disruption of pelvis, if it is stable, good, but the version will be changed for sure.
Yeah. So just for the beginners or who are starting arthroplasty.
Ranshu, can I add a comment here?
Yeah, please. Please, Ramesh.
So maybe I'm slightly different to the others. To me, this will never be a very stable scenario with the pelvis that widely open. It will move to some extent, enough for me to worry about my cup position.
Right.
So I would make an attempt. My first surgery here would be actually an attempt to close that gap, how much ever I can. And if required, I'll put a iliac crest bone graft and actually fuse that area permanently. Because
Pubic
that's
symphysis area.
yeah, symphyseal area. So we have done that in the past, where we cannot close the gap. You put in a bone graft and actually put a plate on top, and that's your pelvis taken care of. 3 months later, you'll probably have a solid fusion. Even if it is not solid, it will be enough for me now not to worry so much about the acetabulum. And then that's the time when I will go ahead and actually do a THR. And of course, my acetabulum is going to be retroverted. So I need to take care of that. My dislocation rates are going to be higher. I am anyway always doing these from the anterior approach, so I don't worry. But that's how the approach for me would be. Slightly different probably to anybody else who might be thinking just going ahead straight away with the acetabulum only.
Rakesh, only thing is will be that this kind of a disruption of the pelvis, that's a very difficult area to graft. And put a
No,
plate.
it's
the complications are also plenty.
He will tell you it's not difficult.
Yeah, what we have done in these cases is we try to build up the pelvis whenever instability is there. We have used a rib graft also. We put a rib, have a plate from one side to another. The rib gives a fusion across. If it's a small defect, we have used iliac crest graft. If it's a bigger defect, we have used a rib into the area.
So Shubhranshu, was this patient
how big is the defect here? Sorry, Rajiv, just before that, Dr. Sen, how big is a defect you have built up?
5 centimeters, 6 centimeters, we have built it up. Basically, in the previous, because this is maybe a stable situation. I don't know about the posterior pelvis.
Yeah,
we get a lot of non-unions in the back with this defect where we cannot close it up. And in those cases, what we do, you put a rib because that can give us a reasonable. We basically, as Dr. Rajput said, want a continuity across it. Until that continuity is maintained, because once it is continuous, your pressures from the limb are likely to be much more physiological than a non-contained kind of a situation. So anteriorly, rib can be as long as possible. You can keep. You had to protect this rib by a plate across, and sometime we have used a internal fixator or anterior supraesternal fixator to protect that area. Once it unites, we take away the fixator off, and then it's a pelvis continuity in the front.
Can I add?
Yeah, Mrinal, you have a comment on this?
Yeah. Sir, actually, I think we should clinically examine these patients if the pelvic compression test is positive. And if it is not very chronic, then we might need to stabilize it. If the pelvis is not moving on compression and the patient is walking with a broad leg gait, these are relatively stable. And the only thing we need to take care is what Dr. Sen said, to take care of the anteversion and the inclination, because otherwise you will place them in retroversion and open.
Yes.
So that is the most
I tend to agree.
Important thing. The other thing I'm concerned here is more of the stem. Yes, sir. The other thing I'm concerned is about the femur. The femur is too much thinned out. There is some kind of, chronic periosteal reaction down at the junction of the upper 1/3 and the lower 2/3. And there we might need to use a modular stem, which might bypass that part and probably correct the anteversion also, because the stem will also need to be a modular stem in this, or a cemented, probably, if the bone quality is not at all good.
Yeah,
very right. So Shubhranshu, what did you do in this?
Yeah. Just, for the, so I think all the opinions are very valid and valid point in this particular case. So for the beginners, just I wanted to highlight a couple of points that in this kind of patients, first do a whole of the femur. Since there is a malunited, there is a fracture malunion, so you have to see the lower part of the femur, that how far you are going to put a long stem or you are going to use a cemented stem. And as you see in the X-ray, AP and lateral, the femur is well united with a good balance there. Please mute others. Dr. Rajiv. There is some distance. Okay. Then you have to do a CT scan. As Dr. Sen told that you have to do a CT scan in order to see the position of the acetabulum. As in open pubis, so if you see the acetabulum is vertical compared to the normal side. So it is an open type of acetabulum. So cup is open, and Mrinal was pointing out. And also the cup is retroverted compared to the opposite side in the axial views. So the acetabulum is retroverted and it is vertical. So these are the two important points one needs to take care while putting the acetabular component. So here basically the acetabular component placement is critical while doing a total hip replacement. So if you see the literature, there are only anecdotal case reports about this. This is a case of chronic pubic diastasis, 5 years old. And clinically we examined, it was quite stable. There is no pain. So these are two types, basically congenital, that is congenital extrophy of bladder when the patient present, or acquired, which is post-traumatic like this in our case. So the chronic pubic diastasis, the acetabulum is excessively vertical and it is in retroverted position. And is it highlighted in the picture that sometimes there is a unused anterior osteophyte which is there, which needs to be either taken out, or with a burr you have to reduce this osteophyte, or else there is an impingement and that may cause posterior dislocation. So there are three important things. So what we did, we went by our posterolateral approach, and the plate, if it is coming on the way, you can take it out, or else you can leave the plate intact. So we remove the plate because we are just at the margin of the cup and we are not able to put the trial cup there. So we took out the plate with the screws, and that is the complete 360-degree exposure of the acetabulum. And we put a trial cup in place of antiversion. So that is the axis of the body. So in about 10 to 15 degree of antiversion only, maximum we put the trial cup there. So first we reamed vertically 38, 39. Once we reach the floor of the acetabulum, then we reamed, giving required degree of inclination antiversion, and in about 43 reamers, it was quite good. And there's a 44 size trial cup there, which was quite stable anteroposteriorly as well as rotationally. But posterior superiorly, it was uncovered. So we had to put an augment there, and it's a flying buttress type of augment, as you can see in the picture. So we put the augment, put two horizontal screws there. Next, we checked in the C-arm. Always check this position of the cup in the C-arm. And while checking in the C-arm, you have to again tilt the pelvis little 20 degree or 30 degree in order to properly see the obturator foramen, so that you can ascertain the position of the acetabulum, trial acetabulum there. And next, we unitize the augment along with the cup with a cement there. This was a trial liner there. Then we did a femoral side, and looking at the quality of the bone, what Mrinal was telling, we used a cemented type of stem there, because there was a defect there and there was a constriction there. So if you have reamed, there is a possibility of causing fracture there. So that's why it is preferred to use a standard cemented type of stem, and used a ceramic bearing there because that was quite stable. And that is the lateral view of this patient. This is just 1 year follow-up of this patient. So cup size was 44, augment was 50 into 10 millimeter, and coral cemented stem we used. Because we tried to use an uncemented stem, even 11 size coral broach was loose, rotationally it was unstable, and also it was the vertical offset was very high. So in order to adjust the vertical offset and give the rotational stability, we preferred a cemented stem on the table itself. And that is 1 year follow-up. I don't have a video because I called the patient for for a video, but because of the rains in Mumbai, he couldn't come. He stays at a distant place. But he sent a couple of pictures that is walking well. Of course, the foot drop is still there. That has not improved. So take-home message. These are anecdotal case reports. The maximum number of cases which has been reported in the literature is this in 2022, Arthroplasty Today. They have reported 4 cases with 6 total hip replacements with a maximum follow-up of 2.5 years, average follow-up of 2.5 years. So that is the largest series which has been reported in pubic diastasis. So pubic diastasis, you have to restore the native acetabular position. It is excessively vertical and retroverted. So pre-op planning involves patients should be internally rotated 20 to 30 degrees with respect to radiographic BEM, in order to obtain a normalized AP view of the operated hip and operative hip or hemipelvis. So you decide about the normal position by looking at the obturator foramen. Intraoperative fluoroscopy, when you do, you view the recreated during surgery to ensure the acetabular positioning. And during this position also, you have to keep little 20 to 30 degree internal rotated view in order to check, your cup position. Prefer to use larger head sizes or dual mobility bearings that will maximize the stability. The risk is that excessive unilateral hip anteversion may give rise to posterior impingement and anterior instability, or cup may dislocate posteriorly. And these are a group of challenging patients, but if you have planned properly and executed a plan on the table properly, it may lead to a very good long-term outcome. I thank you for a patient hearing. And those who are, those who want to read further, you can read this article. And I take this opportunity to request all the members of IAA who are there to support my candidature for Vice President of IAA. The elections are going to be in September, October this year. I thank you for a patient hearing. Thank you.
Thanks, Shubhranshu. That's very nice. Nice presentation. Now, before we, Ronan, before we discuss, since we have some time, I'll quickly show 4 or 5 slides to complete the jumbo cup and the gription cup. Is it okay, Ronan?
Yes, I think that's fine. But there are a number of talks to actually cover. So, I mean, why don't we have the discussion first, and then maybe we could, if we have the time right at the end,
Sure.
have about 20 minutes and 5 talks to talk about.
Yes.
Let's see how it goes.
So let's have the discussion first.
I think so,
and
yeah.
if we have time, we just talk about the jumbo cup in a slide just to complete the topic. So Shubhranshu, your talk was excellent about the pelvic deformed pelvis, and that actually deformed pelvis is very different than the so far what we discussed. So did you have a problem in finding out the right orientation of the cup?
No, that's why we had decided pre-operatively that we'll put the cup in little, less anteversion, and we'll put the cup, we'll give the inclination properly. So after giving around 40 degree of inclination, there was posterior superior defect. That's why we had to use the augment there.
All right. Dr. Singh, you have a question, please.
Yeah, there was a question in the chat box in the very start of it, that if we are likely to buttress the posterior wall, do we first fix the cup and then put a graft, or we first put a graft and then put the cup inside it?
Yes.
Our perception has been that we hold the cup in the direction, we ream along with the graft, but we don't tighten it up. Once we have done the adequate reaming and then we have put the cup also, then we do final tightening of the screws along the graft to further consolidate it, because we are not depending upon the graft for stability. We are augmenting the stability, and we want the graft to encroach very well over to the graft. So we will tighten the screws in the end again.
So the sequence will be
to put it in a chat box here.
Right. Yeah. The sequence will be to put the plate first, if it is required.
Yes.
Then the graft, impacted sufficiently, and then put the cage or the cup.
And
Rakesh,
thereafter tighten the final screws.
Right. Rakesh, you have a comment or a question?
Yeah, Rajiv, quite a few. Actually, Dr. Sen was talking about when we are putting graft holding with screws, not the plate one. Plate one, you always have to put plate first.
Yes.
But for the only ones where we are just supplementing, maybe for future in case, where you have a small defect, where you're putting in a cut allograft, in those cases, I think the step with Shubhranshu and we are almost similar, maybe slightly different in technique. You are actually going to ream the first, get a good cup size, because that's not dependent upon your defect. That's dependent upon your cup, which you have templated also. So you ream it, then perhaps get a cup size right, then probably put your graft hold with a screw, and you're going to put slightly bigger graft, not the one just on the edge, but slightly bigger. You put one screw, one K-bar, and then again you do gentle reaming to actually ream off this portion which is impinging upon your cup side. Now you put your cup in, fix your cup back, and then come back, take out that K-wire, and then finally put that screw back. So that now you have a good fixation of the graft itself, not compromising the cup based on the graft impingement.
Yeah, and one more clarification.
Yeah, it's more
you'll
or less
agree with me, Rakesh, that if you are using the cup and the augment, say gription cup and an augment, then you have to unitize them.
Absolutely.
Because that gives the primary stability. Mrinal, you had a Rakesh.
My questions are still here, both to Mrinal and Kishore. I think both the cases showed very well that if you put in a cup, in these sort of cases where we have a fracture acetabulum, which the anatomy is distorted and the fitting is not very well, you need to get the purchase inferiorly in pubis and perhaps also into the ischium. And
right.
both the cases, the cup actually flew off in what we call as an abduction failure. And the cup starts tilting. And also what happens is in these cases that we invariably end up putting screws. And what Nikhil also pointed, that if you put screws now into your posterior one, you can actually see visibly the cup tilting in front of your eyes. And the cup which you have started off with 45 degrees now becomes almost 55, 60 degrees. So it invariably happens. And you can see that under vision in the OT, both this thing. But I have a question for Kishore, if he's still here. Kishore, are you here? But maybe Dr. Sen and others.
You can put it to the panel, please.
Yeah. So Dr. Sen, on others, what do you really feel of distraction techniques which Kishore has used in acetabular fractures?
If I have to say, we actually look at distraction technique in a chronic discontinuity when there is a reasonable amount of a fibrosis around, where distraction allows the cup to fit in and then subsequently it collapses back. What we have seen in acetabular transverse fracture, which are parallel to kind of a discontinuity, more the size your cup, I have used till 68 sizes also. Bigger the size you use, this keep on distracting. So what we have found in post-traumatic situation, as an acetabular surgeon, we put a column plate, must put a column plate first, because that gives a reasonable amount of stability. And then what we did was, it was some time back, about 10 years back, when we had somebody has guided us that you can put an anterior column screw, but anterior column in those cases reasonably destroyed. You can't put a screw in. So we use a recon plate with the screw along the recon plate toward the ilium and then screw towards the pubis. And that gives you anterior continuity. And with that area, the posterior and anteriorly stabilized. Now we can put a cup which will give us a reasonable stability. So in acetabular fractures, rather than getting a distraction technique to help us, we have used a stabilizing the both columns as an acetabular surgeon and then putting a cup, which obviously will be bigger, but that is the way we have done it.
So Rajiv, my understanding is also,
Yes,
my understanding is also the same. So what happens in chronic, let's say in a revision case scenario, your bone has become deficit, you have a discontinuity, but your soft tissues on behind are very fibrotic. So you can use this strength of this fibrotic tissue when you're using the distraction. Whereas in our pelvic fractures, you've lost this soft tissues also because you have a fracture. It has eaten away into, and because now you have a non-union, you cannot guarantee about a good fibrous union about these soft tissues, which also had almost fractured. So distraction techniques generally do not work in acetabular fractures, and we rely more on either posterior wall fixation and the technique which Dr. Sen said. Dr. Sen, you were talking about doing it from inside, the recon plating, not from outside.
Not from outside. Outside, actually, either you have a separate area, you have a separate.
Then you have a separate approach in it, but here you can go from inside. Yeah,
from inside.
That's a very good technique, actually. What Dr. Sen just said.
Ronan, you had a comment.
Basically, I just wanted to ask, I mean, the distraction technique would probably apply, as you say, in a patient who has chronic discontinuity. Now, at what stage would you decide that it's become chronic? I mean, 6 months, 2 years, 5 years, when would you say that the fibrosis is adequate to try out the distraction technique? That, I think, is one question. And as a corollary to that, I mean, the long discussion we had in Shubhranshu's case, I mean, there again, you had the symphysis pubis, which had opened up. When do you think it's stable enough for him to start deciding that we don't need to do anything and we don't need to fix it with a rib graft or a pubic graft or a plate, and then we can go ahead with our total hip replacement? So I think both cases are reasonably similar. I mean, we're depending on fibrosis to hold our fixation or the long-term outcome. So when would you think, and what does the panel feel about it?
Yeah.
So Shubhranshu, yeah, Dr. Sen.
And now we have two different scenarios. One is a revision scenario in which there is no discontinuity, as Dr. Rakesh said, in the soft tissues. It was a lysis at a level where we got discontinuity, but every soft tissue was intact. While in a post-acetabular situation, there has been a disruption of every tissue around. So it is the mechanism with which the discontinuity occurred. It is not the duration, as you said it. If there is a discontinuity caused by the revision, the day it is a kind of a chronic situation. While in this thing, it never becomes chronic because discontinuity in pelvic trauma stays always. You cannot distract it. So you're very right in the differences in a revision scenario. It is a discontinuity. Distraction can work. In a acetabulum fracture, cannot work because the soft tissues are already gone.
It's an important
Mrinal, you have a
differentiation to
comment
make.
on this?
Yeah, sir, I think I agree with what Dr. Sen and everyone is saying, but I think we should judge intraoperatively. If you're putting a larger size cup, say a size 4 than what you have reamed, and you get a pelvic recoil and your cup is stable enough, you check it on table and then you can put multiple screws and stabilize it further. This usually will not happen in a trauma case, in a old acetabulum fracture. So it will keep opening, like what Dr. Sen is saying. Even you go size 6 or 8 above, it will still keep opening. There you should always keep a plate and stabilize that column and then put in a cup. That is exactly the approach to be.
And you will agree,
exactly
Mrinal.
Yes.
Yeah, and Mrinal, you'll agree with me that apart from the superior screws, you have to put the importance that is coming up now, the ischial screw and the pubic screw. I think that is very important.
That's what I explained in my
because
talk.
That's right. Yeah, stabilizing it all around. Dr. Chen, you agree with this?
No? And you have to put that screw first. Rajiv,
Yes.
The
that
kickstand
screw you have to
yes.
put kickstand screw rather than putting the superior screw first. That's what also Nikhil pointed out. Because
for our
that
younger surgeons, what Dr. Shurvanshu is saying very rightly, that if you use the superior screws first, that may change the inclination of the cup.
inclination of the cup, and also cup will be pulled superiorly. So
Right.
if you take the cup superiorly, so it will become the center of rotation will be superior. So if you
Right.
fix the ischium and PV screws first, then that restores the center of rotation as well as the you can get a better inclination and version there.
Very
And
right.
regarding Ronan's question, when you decide that when pelvis, this pubic diastasis is chronic or it is acute. So clinically, when you assess, you do a pelvis compression test. And if it is not painful and the pelvis not moving, that is the time. Of course, the duration also will tell you. My case was a 5 years old and there was no pain at all when you do a pelvis compression. So that's why it was not required to be done. But if there is it is painful and you are able to compress the pelvis, probably it's better to fix it first before doing anything. Yes, sir.
Let me just add one thing.
Yes,
Dr.
Sen,
Let me add one thing. Whatever compression test may do, because we cannot induce the same forces as weight bearing induces. So the clinical assessment, whether the hip pelvis is stable or not stable, is the painful condition of the patient. If it is a painful hip, it is unstable. If it is a painless hip, it is stable.
Very right. Yeah.
I agree.
Mrinal, in your case, you pointed out one thing very right, which is important, which I just want to repeat it for the younger surgeons' benefit, that whenever we do a revision, the culture is very important, and many a times you find the infection as the culprit, because of which the loosening or the defect or the failure of the earlier cup or earlier cage is there. And there the ultrasound guided aspiration is very important. Yeah, I think that was a very, very important point, which we all should remember in all revision cases.
And one more point that in this literature, they have described more than 8 centimeter pubic diastasis is described as a severe chronic pubic diastasis. That's what
Very right.
they have
Yes.
mentioned in the literature.
Yeah.
And most of the bladder extrophy are severe pubic diastasis. Those are the cases where they have not used, they have not operated upon that. They have just done a hip replacement, wherever it is painful.
All right. And also in a disrupted pelvis, the posterior fractures mostly unite. And it is the pubic disruption which remains. And that too, if it is few months later, you'll find it a stable pelvis. As you rightly mentioned, if it is not painful, it is a stable pelvis.
Right. Yeah.
Right.
One,
any more questions?
Already, yeah.
Yes. So we have covered up almost all topics. The two things that I'll just mention.
Why don't you just complete your slides that you were going to show?
Just 2 slides, maybe I'll just to complete the things. Maybe I'll just come up. Yeah. Can we see now?
Yes.
Yep.
Yeah, so you can just have just to complete the topic, you can have a jumbo cup. Just 1 minute. You can have a jumbo cup placement, which can take care of the defects, mild defects, and also a situation like this when you have, you can use you may just use the jumbo cup, like you see a situation where there is a central defect, but as you can see that periphery is intact. In this kind of a situation, you can get away with the graft in the central defect and just put a larger cup.
Multiple cup.
Yes, use the bone graft and use the larger cup with multiple screws, and I think that is able to take care of the situations very well. And this cup was very stable in this situation. So that just to tell our colleagues that this is also one method, not necessarily that you have to use the augments or you have to use the cage. So I'll stop this presentation here, and I think we have discussed, Ronan, one difficult topic with very interesting types of situations that we can find ourselves in, and how to bail us out in these difficult situations. I think that's a wonderful presentations. Thank you so much.
Before we close, I'd just like to say that I'd really like to thank Dr. Sen for organizing this thing, and the format was very good in the sense that everyone presented cases rather than having long discussions, and the discussions were actually very fruitful. So I think that this is an excellent form. Thank you, Dr. Sen, and I'd like to thank Dr. Nikhil as well, though he's not here at the moment, and everyone for taking part, and all the people who've listened in as well, and Rajiv for coordinating this in his inimitable style. So thank you so much, Rajiv.
Thank you so much, Ronan. I think it's